Rheumatoid arthritis, a case study in evidence-based practice, presented by Anita Somvalrea. Subjective. Patient complaints. I have pain in my hands and wrists, and it has been worse in the morning for the last 10 days. History of present illness. A 60-year-old female with a history of hypertension, high cholesterol, hypothyroid presents to the clinic with complaints of pain in her hands and wrist. She noticed pain has started 10 days ago and is worse in the morning. The pain is sharp at times. The patient reports pain 7 over 10. There's a constant burning sensation. Moving her hands is very painful and touching makes the pain worse. The pain has She's tried icing the area but not very effective. The patient reports she takes ibuprofen 200 milligram, 2 capsules every 8 hours per day, and it helps. The patient reports that the pain is constant in her fingers, and also she has mild tenderness in both her wrist on and off for the last 6 months. Denies fever, chills, nausea, vomiting, diarrhea, constipation, headache, or dizziness. Disease denies abdominal pain, chest pain. She usually sleeps well, but lately her sleep has not been great due to anxiety. Past medical history. Patient has previously been diagnosed with medical conditions of hypertension, hypercholesteremia, hyperthyroidism. The patient denies history of respiratory disease. Patient reports she had measles as a child. Patient has never been in the hospital or had any surgery. Family history. Patient reports that the father had high cholesterol and hypertension. The patient's mother had diabetes and RA. She has no siblings. Social history. Patient is semi-retired and works in a local library. Patient is married and lives with her husband and two children and is currently healthy. She describes the family as supportive, close to her parents' disease. She is Catholic and goes to the church every weekend. She exercises regularly, lifts weights occasionally, but has not been able to do so in the last 10 days. She tries to eat healthy. She denies drinking, smoking, or any other recreational drug. Medications. Patient is currently taking ibuprofen 200 milligrams, 2 capsule QI for pain, levothyroxine 75 mcg tablet PO daily, aspirin 81 milligram PO daily, losartan 25 milligram tablet PO daily, rovastatin 25 milligram tablet PO daily, multivitamins or supplements. She does not have any allergies, no known drug allergies, food allergies, or environmental allergies. Health maintenance. Patient is up to date with all immunizations and her colonoscopy. Last physical was a week ago when the labs were done. Last PHQ-9, low score, she was 5. Review of symptoms. Everything is normal, general, constitutional. She denies any fever, chill, malaise. Um, Head and neck exam, everything is normal. Patient wears reading glasses. Perla. Patient states she has pain in her hands and wrists, which is worse on touching. Cardiovascular denies any shortness of breath, chest pain, palpitations. Respiratory, patient denies asthma, dyspnea, chest is symmetrical. Integumentary skin is intact. GI, patient does not have any problem voiding or any decreased appetite. Objective. Vital signs. Blood pressure 128/74, heart rate 65, respirations of 16 breaths per minute, temperature 98.6 Fahrenheit, oxygen saturation 98%, height 5'4", weight 160 pounds. BMI is 27.5. General patient is malnourished, overweight, has no apparent distress, alert, awake, oriented, and she answers all her questions appropriately. Head and neck exam within normal limits. Lungs are clear on auscultation. Musculoskeletal. Patient has pain in her hands and wrist. No swelling and decreased movement in the wrist. Diffuse swelling is present in all small interphalangeal and metacarpophalangeal joints with the redness of the skin. No visible deformity, painful to touch. Cardiac regular rate, rhythm S1, S2, no murmurs. Patient does not feel any tightness in the chest. Patient symptoms are summarized here and the lab test. Pain and swelling in small joints of fingers on both hands, morning stiffness, decreased movement, diffuse swelling is present in all small interphalangeal and metacarpophalangeal joints. There is redness of the skin over the swelling, increased ESR, increased TLC, a rheumatoid factor, IgM positive, anti-CCP is positive, CRP is positive, rheumatoid factor is positive. And if you see the slide on the right, Everything is normal except for the inflammatory markers, they are positive. Uric acid is normal, therefore rules out gout. Calcium is normal, TSH is normal, therefore there is no hypothyroid issues. Assessment. Impression with ICD-10 codes. Working diagnosis. Rheumatoid arthritis. Patient has all main symptoms of RA, such as morning stiffness, pain, and swelling of small joints, of interphalangeal and metacarpophalangeal joints. The patient has a family history of RA. Her mother has it, thus, therefore, there's a genetic factor. Upon examination, patient had increased ESR, positive anti-CCP, CRP, and RA factor. They indicate increased inflammation and thus rule out osteoarthritis and indicate RA. The patient does not have any rash, thus ruling out psoriatic arthritis. The joints are soft, have swelling, and are painful, thus indicating RA. If the patient was osteoarthritis, the joints would have had a clicking sound. The first symptom is pain and swelling. The patient is afebrile, thus it rules out lupus. The patient does not have any sensitivity to a cold, thus there's no Raynaud's disease, which also rules out lupus. And the patient does not have any malar rash, also rules out lupus. Many diseases can mimic RA. They include autoimmune disease that are other forms of arthritis, then there are bacterial joint infections and other inflammatory diseases. The most common diseases that can be confused with RA are psoriatic arthritis, gout, osteoarthritis, and lupus. If there's infection, viral infection, it'll usually clear up in 6 weeks. So if the symptoms last less than 6 weeks, it's usually viral. If the symptoms last over 6 weeks, it is more towards arthritis. First differential diagnosis is osteoarthritis. This is not an autoimmune disease, usually caused by wear and tear of the joints, and it's seen in older patients. Morning stiffness only lasts less than 30 minutes. Unlike RA, the activity makes osteoarthritis worse. There's no inflammatory markers. There's clicking sound in the joints, soft swelling tissue. X-ray will show bone spurs visible. Swelling and bone deformity also visible on X-ray. There's lack of space between the joints, and it affects tend to be only one-sided, unlike RA that are um, is symmetrical. The joints affected are base of the thumb, one knee, one hip, one big toe, DIP joints. Psoriatic arthritis. Um, this is an autoimmune arthritis, often confused by rheumatic arthritis. The symptoms can develop at any age, but most common are between ages of 35-55. It affects men, women equally. Arthritis can occur before the skin disease, and sometimes it occurs with mild skin involvement, such as only nails or scalp. Develops in people those who have psoriasis. Symptoms are painful and swelling of the joints, appear red and warm. Joint stiffness could be tenderness of the pain, and heel psoriasis, and fatigue. There is no rheumatoid factor present, but there is psoriatic arthritis will have CCP antibodies. In the X-ray, psoriatic arthritis will see inflammation where ligaments and tendons are attached to the bone. Third is lupus. The first complaint of lupus is usually fatigue and exhaustion, unlike rheumatoid arthritis, where the first complaint is joint pain. The joint pain follows the exhaustion, and that's when the patients come to the doctor with the distinct feature. Lupus will have butterfly rash called malar rash, involves cheeks and nose. They also have fever, um, joint pain. There's no joint deformity. There's increased sun sensitivity. There are pale anemic. Another distinctive feature is that the joints turn pale or bluish when exposed to stress. They and cold. They have dry, itchy eyes, difficulty in breathing, nausea, vomiting, abdominal pain, indigestion, weight loss. There's history of seizures. There's increased tendency to bleeding. Patients will have frequent headaches, memory impairment. Younger women will have frequent miscarriages. The lab test for lupus sounds like um, uh, ESR, liver kidney function test, anti-nuclear antibody test, urine analysis. The imaging and the doctors want to know how much of the organs are affected by lupus. These include X-rays, MRI, also echocardiogram to see how the heart is doing. Sometimes a biopsy is done to determine the extent of kidney involvement, and the skin biopsy can also be done. The plan. The patient is in good condition. She's overweight, has family history of RA, and tries to eat healthy. Pharmacologically, she had a moderate score of the disease. Following guidelines of ACR 2021, the patient was prescribed the following medications: methotrexate 15 milligram once a week, folic acid 400 milligram daily, ibuprofen 400 milligram Q6, and Xanax was prescribed for anxiety. Non-pharmacological, physically active helps to keep the stiffness away. Keeping a healthy weight helps in the overall health of the patient, decreases the progression of rheumatoid arthritis. The key is to avoid injuries and repetitive motions, as you do not want to cause further inflammation. It is important to keep your mouth healthy as well. The follow-up is between 2 to 3 months to evaluate the medication is effective and if the symptoms are not getting worse. Discussion: rheumatoid arthritis. Rheumatoid arthritis is most common autoimmune type of arthritis. This is when the body starts to attack its own tissues and causes inflammation of the joints and various other organs, resulting in pain, stiffness, swelling, decreased flexibility of the joints. Rheumatoid arthritis never goes away. It is chronic, disabling autoimmune disease that is characterized by inflammation of the joints and synovitis of small, large joints, which cause swelling and stiffness. It is progressive disease, leads to joint destruction. Usually people develop this disease anywhere between 40 to 60 years of age, but it can arise anytime. There is one of the common diseases in primary care, especially when it's first diagnosed. Signs and symptoms. The symptoms of rheumatoid arthritis are bilateral, symmetrical, include pain, aching, joint stiffness in more than one joint, tenderness, redness, warmth, and swelling in all the joints associated. There's weight loss, fever, fatigue, and redness and weakness. There is joint deformity, morning stiffness, dryness in eyes, dry mouth, abnormal um, colored urine. There could be no urine due to kidney impairment. They can have numbness and tingling in the hands and feet, difficulty in breathing, pale skin, chest pressure. They can also have flares and remissions. Flaring is when symptoms suddenly appear and get worse, and there can also be remission when there are no symptoms and they all go away. This chronic inflammation is long term, leads to loss of cartilage, making the joints weak and deforming them. There are other kinds of rheumatoid arthritis. There is juvenile rheumatoid arthritis, which is from children's year 1 to 6. They have stiff swollen joints and they also have rash and fever. Um, there is also difficulty to treat rheumatoid arthritis, also known as resistant or refractory rheumatoid arthritis. There is persistent inflammatory refractory rheumatoid arthritis known as PIRRA, where there is a lack of efficacy of the therapies and constant inflammation. Refractory RA is also known as non-inflammatory rheumatoid arthritis, NIRRA, where there is a disease without inflammation. Identifying these will detect the treatment and their management. Polyarticular arthritis, acute explosive. It arises overnight over the course of few days. Palindromic presentation symptoms. These are transient, they arise and then they disappear and appear in some other joint, and then the symptoms only last a day or week before they completely go in remission. Diagnosis of RA. The key to diagnosing rheumatoid arthritis is ruling out any other diseases and condition that mimic rheumatoid arthritis. Physical exam is very important. Swelling, redness of the warmth, any deformity, check for muscle reflexes. Also check if the body parts show any disease involvement. X-rays, they should show chronic damage but no inflammation. Ultrasound and MRI, you will see inflammation in the joint lining in the ultrasound. Thus it is almost a gold standard. MRI is done when there is other inconclusive. Lab test: erythrocyte sedimentation rate detects inflammation in the body is elevated. C-reactive protein (CRP) blood markers for inflammation and increases the acute phase and is increased in inflammation. A rheumatoid factor, this is an antibody that is present in the blood. 80% of the patients who have rheumatoid arthritis, the higher the level of this antibody, the more the aggressive is the nature. Reviewing health history is very important, as a health history will give all the symptoms, and proof needed to know the um, severity of the situation of the symptoms to identify RA. It is important to diagnose rheumatoid arthritis as soon as possible so they can be referred to a rheumatologist. The key here is controlling the symptoms and preventing further damage to the joint. Therefore, the earlier the treatment, the better the prevention. Um, one should know the risk factors so one can treat the patient accordingly. The age is any time, it can happen at any age. Women are most likely to be affected due to um, more times. Family history and genetics. If the family member has RA, you are most likely to develop RA. Smokers have a higher risk. Obesity increases the risk of disease. Periodontitis is associated with developing rheumatoid arthritis. Lung diseases and airway may also be associated. Occupational exposure, working with silica, wood, asbestos have been increased the risk of developing RA. Certain viral condition, bacterial causative agents have been speculated. Evidence-based plan based on clinical guidelines. Pharmacological treatment options for rheumatoid arthritis are primarily the disease-modifying drugs, such as the disease cannot be treated but only modified to bear the pain. The disease-modifying anti-rheumatic DMARDs are used to treat the diseases. They help in slowing down rheumatoid arthritis, therefore it does not get worse fast, and they control joint swelling, preventing joint destruction. There is also a resistant kind of rheumatoid arthritis that does not respond to normal drugs, like DMARDs, and that modify the symptoms of the disease. Then you need a different kind of DMARDs that are known as biologics that block the immune system that causes rheumatoid arthritis, and they help in prevention and progression of the joint destruction. The disease modifying anti-rheumatic DMARDs are the meds that treat RA and are key to achieving remission. There's a different classes of DMARDs and categories. One is conventional synthetics, second is biological. Under that, it comes tumor necrosis factor inhibiting TNF, T cell costimulatory inhibitor, interleukin 6 receptor inhibitors, anti CD20 antibodies, and the third kind are targeted synthetics DMARDs. Evidence-based plan clinical guidelines. According to ACR, mm, patients with rheumatoid arthritis, the first choice for initial treatment, low score, and the Nexium can be used. Methotrexate is recommended for the initial treatment of the patients with RA with moderate to high disease. ACR recommends RA treatment should be targeted to standardized disease activity scale. If initial treatment with methotrexate is not successful, then triple therapy with addition of sulfazyme and hydroxychloroquine is recommended, which is proven to be more effective as adding as biological or targeted synthetic medication. Low score for the first choice is hydrochloroquine, sulfazyme. Moderate to high disease activity is methotrexate, is the best initial treatment. Methotrexate is a conventional synthetic DMARD and is stronger than hydrochloroquine or sulfazyme. Combination therapy is not recommended as it increases toxicity and cost. Glucocorticoids are not recommended. It's aimed to treat target. It is based on the disease activity. Um, the aim is treating, getting them to a low score or remission. Methotrexate is usually started at 15 milligrams, and then it's given, if the patient cannot tolerate, it's divided into multiple doses in 24 hours. Folic acid should be given. And if they can't tolerate PO, subcutaneous methotrexate should be given. If that is not effective, then they should switch to DMARDs. There are some nice there are guidelines, European guidelines of Nice and Euler listed here. These are some scale flow sheets for RA treatment and difference between European and American guidelines. These are non-pharmacological recommendations, what to do with exercise, rehab, diet, and additional. And the red flags of RA are if they're visibly The worsening symptoms because this shows disease progression, visibly swollen tender joints, more frequent flare-ups, extreme fatigue and tiredness, decreased range of motion, elevated inflammation markers, numbness of fingers, and rheumatoid nodules. These are the questions, and there are 5 questions, and these are the references. And thank you.